So the alpha granules secrete the adhesive proteins. So things like von Willebrand factor, P-selectin, fibrinogen, thrombospasmodin, and the platelet activating factor. They also secrete pro-inflammatory factors like platelet-derived growth factor, PDGF, as well as thromboxane A2 and CD114. They also secrete prothrombotic factors like factor 5 and factor 11. And then we have the dense granules, which secrete ADP, ATP, serotonin, calcium, and magnesium. So the main players here from the degranulation of the platelets are ADP and thromboxane A2. Yeah, and the ADP and thromboxane A2 help with recruitment of platelets. And then this is what leads to the next step, which is platelet aggregation. So because of the ADP and the thromboxane A2, which cause more of the platelets to be recruited or aggregate at the site of the injury, they then begin to bind to each other through fibrinogen and the GP2B3A receptors. And that entire process is accelerated by platelet activating factor, which is secreted by the alpha granules of the platelets. So that is a basic rundown of platelet plug formation in a nutshell. Yeah? So platelets have a lifespan of about 7 to 10 days. As we mentioned before, they're synthesized in the bone marrow from megakaryocytes by a process known as budding. And we know platelets don't have nuclei. About 30% of your platelets end up in the spleen, so they're stored in the spleen. And the platelets consist of a peripheral zone and the cytoplasm. And the peripheral zone is a membrane which has the glycoprotein coat that we mentioned. It contains those receptors for von Willebrand factor, as well as receptors for collagen and fibrinogen, which are the GP1B and the GP2B and 3A receptors. And then there are phospholipids, things like platelet factor 3 or PF3. And then in the cytoplasm, we have alpha granules and dense granules, as we've mentioned before. And it also contains actin and myosin fibers. And those actin and myosin fibers contract and actually help to change the shape of the platelet, which is important in the activation phase of the platelet plug formation. Now, there are a number of antiplatelet therapies that patients commonly take, which have an effect on the function of platelets, and they're important to know about because they can affect surgery. So we have aspirin, which is a very common drug. So it inhibits cyclooxygenase or COX, and it does when it does so, it decreases the production of thromboxane A2 and prostaglandins. And as we know, thromboxane A2 is one of the drivers of platelet aggregation. And so in inhibiting cyclooxygenase, it inhibits the arachidonic acid pathway, and therefore you have less production of thromboxane A2, which leads to less platelet aggregation and less vasoconstriction. Yeah. Clopidogrel is one of the other medications, and it works by inhibiting platelet activation and aggregation by binding to the P2Y12 class of receptors on platelets, and these are ADP receptors that it binds to. So these are essentially ADP receptor inhibitors. So clopidogrel is an ADP receptor inhibitor, and as we know, ADP is very important in the recruitment process of platelet activation and aggregation. One of the other medications, we have the GP2B3A receptor inhibitors, like abiciximab, which bind to those receptors and help to prevent platelet aggregation. So those are important to know about. Yeah, clopidogrel in and of itself can be stopped about 3 to 5 days prior to elective surgery, and aspirin can be stopped at the time of surgery and cardiac surgery, and can actually be continued in many surgical procedures except for neurosurgical procedures or eye surgery. Yeah, and so we come to the third part of hemostasis, which is the coagulation cascade. So we finished vasoconstriction and platelet clot formations. We're going to look at the coagulation cascade. So this can be a little difficult to remember, but what is essential is that we remember that there's an intrinsic and extrinsic pathway which lead into a common pathway. And so we'll start with the extrinsic pathway. It starts with some sort of tissue injury or trauma, which leads to the release of tissue factor, and the tissue factor catalyzes the conversion of factor 7 to 7A, and then binds to activated factor 7 or 7A, and that feeds straight into the common pathway to help in the activation of factor 10 to 10A. On the intrinsic side of the pathway, prekallikrein helps in the production of kallikrein and kininogen, and then that then catalyzes the activation of factor 12. HMW, or high molecular weight kininogen, helps in catalyzing or the activation of factor 11. So it's 12, 11. And then with the aid of calcium, factor 9 becomes activated. So it's 12, 11, 9. And then activated factor 9 feeds into the common pathway to help in the activation of 10 to 10A. This process is also aided by the platelet phospholipids, as well as calcium and factor 8. When we come into the common pathway, we have factor 10, which becomes activated. Factor 5 also becomes activated by protein C and calcium, and both of those factors, 10 and 5, so 10A, 5A, as well as prothrombotic activator and calcium, help in the conversion of prothrombin to thrombin, which is factor 2 to 2A, and then that helps in the conversion of fibrinogen to fibrin, which is 1 to 1A, and with the aid of factor 13 and calcium, it forms a cross-linked fibrin clot. Yeah. Now, some of the important factors involved here have certain names. So actually, for example, factor 12 is called Hageman factor, H-A-G-E-M-A-N, Hageman factor. Factor 9 is known as the Christmas factor because the deficiency of factor 9 leads to hemophilia B, which is also called Christmas disease. Factor 10 is called the Stewart power factor. Factor 4, you may have noticed, you don't see that number in the pathway at all. Factor 4 is actually calcium, yeah. And then the tissue factor is actually factor 3, yeah. You don't see the number 3 in the pathway at all, but it's known as tissue factor. Some of these factors maintain other names. The entire coagulation cascade can be broken down into 3 steps. So it can be broken down into 3 parts, which is the extrinsic pathway, the intrinsic pathway, which both then feed into the common pathway, but then it also has 3 stages. So the first stage is the formation of prothrombin activator, and then the conversion of prothrombin to thrombin, and then the conversion of fibrinogen to fibrin. So you will see, therefore, that it is the combination of the intrinsic and extrinsic pathway feeding down into thrombin, which helps to form the prothrombin activator. And then the last two stages are both parts of the common pathway as well. These coagulation factors can also be placed into different groups. So there's the fibrinogen group, the prothrombin group, and the contact group. So the fibrinogen group of factors are factor 1, factor 5, factor 8, and factor 13. And it's easy to see how those play in here. Factor 1 is fibrinogen, factor 5 feeds directly into the prothrombin to thrombin conversion. Factor 8 it goes into the 10 to 10A conversion, and factor 13 goes into the formation of the cross-linked fibrin clot from fibrin in and of itself. Then the prothrombin group of factors are 2, 7, 9, and 10. And these are the vitamin K dependent factors essentially. And these are the factors that are inhibited by warfarin. And we'll talk about that a little bit later. And then there's a contact group of factors, which are factors 11, factors 12, which are the first two factors involved in the intrinsic side of the pathway. What is important to note is that these two factors are not consumed in the coagulation process, and so they're always present in the serum to some extent. Now, when we have factor deficiencies, for example, factor 8 deficiency, it results in hemophilia A. A factor 9 deficiency results in hemophilia B, as we mentioned, is called Christmas disease. Now, in testing these, we have a few tests. We have the PTT, which is the partial thromboplastin time, and the PT, which is the prothrombin time. And the prothrombin time evaluates factors 2, 5, 7, 10, and 1. So I guess if you put that in order, it's 1, 2, 5, 7, 10. And then the PTT evaluates factors 12, 9, 8, 10, 5, and 2. So the two factors that are common to both the PT and the PTT are factors 10 and factors 5, which are both parts of the common pathway. In another way of thinking about it is that the PT essentially helps you to evaluate the extrinsic pathway because of its evaluation of factor 7, and the PTT helps in the evaluation of the intrinsic pathway, primarily because of its testing of factors 12 and 9. Yeah. Now, some of the medications that are used which work in the coagulation cascade include things like warfarin, rivaroxaban, and heparin. So warfarin is a vitamin K antagonist. So you'll see it in this diagram here. Warfarin inhibits vitamin K epoxide reductase in the liver, and that depletes the reduced form of vitamin K in the liver, which serves as a cofactor in the synthesis of factors 2, 7, 9, and 10. And of course, this effect can be reversed with the use of vitamin K itself. So whether it's through oral ingestion or an IM injection. Then we have rivaroxaban. So rivaroxaban is a factor 10A inhibitor, and there's no reversal for that particular drug. Heparin works by inactivation of thrombin as well as factor 10A. So you can see the heparins, they light up here, these red boxes, and it's primarily because of the inactivation of thrombin. And the way they work is by binding to antithrombin 2 or AT2. yeah, which is an enzyme inhibitor, which then inhibits the factor 10A. The reversal of heparin is usually with protamine sulfate. And then finally, we have direct thrombin inhibitors. These are medications like dabigatran, and those work by the inhibition of factor 2A, which is thrombin. Okay? So there are a few guidelines for the use of warfarin in patients. So those who are at moderate or high risk of hemorrhage, but who have a low risk of thrombosis. For those patients, you can stop warfarin 5 days preoperatively, check the INR. If the INR is less than 1.5, you can proceed to surgery. If it is more than 1.5, then you want to give IV vitamin K, about 1 to 3 milligrams. And once the operation is done, you can restart warfarin on the evening after surgery once hemostasis has been secured. If the patient has a moderate risk of hemorrhage from surgery, but a high risk of thrombosis, then in those cases, you can stop the warfarin 5 days preoperatively, bridge with low molecular weight heparin, giving a last day dose 24 hours before surgery, and then restart on this low molecular weight heparin 48 hours afterwards if there's secure hemostasis and if the bleeding risk is not high. For patients who require semi-urgent surgery, that is surgery to be done within 6 to 12 hours, the recommendation is that you stop warfarin, give IV vitamin K, and correct the INR over a period of 6 to 8 hours, and then proceed to surgery. If there's emergency or life-threatening bleeding, emergency surgery or life-threatening bleeding, stop warfarin right away, give 25 to 50 international units of prothrombin complex concentrate, and as well as 5 milligrams of IV vitamin K. In cases where the PCC, the prothrombin complex concentrate, is not available, then fresh frozen plasma can be used. One of the disadvantages of using FFP versus PCC is that it produces suboptimal anticoagulation, suboptimal coagulation by comparison. When it comes to the use of heparins, it is recommended that for unfractionated heparin, you can stop infusion 6 hours before surgery in order to have full reversal unless the patient has renal dysfunction, in which case it should be stopped for 12 hours or more prior to surgery. For low molecular weight heparins, if the patient is on a prophylactic dose, they can receive their last dose 12 hours before surgery. If they're on a therapeutic dose, then you want to stop at 24 hours before surgery. We talked a little bit about when to stop aspirin and clopidogrel as well. Some of the options for fibrinogen replacement in patients include things like FFP, cryoprecipitate, and fibrinogen concentrate, and those can be given intraoperatively as well. So now that we know how the body achieves hemostasis, we need to know how we achieve hemostasis during surgery. And there are a number of methods of doing so. So most commonly, there are mechanical methods, and there are pharmacological methods, and there's also surgical cauterization, as well as blood transfusion or blood salvage. So some of the mechanical methods, the use of hemostatic clamps, ligating clips, staples, sutures, the use of bone wax, digital pressure, just pressing on the wound, the use of external bandages, or the use of a tourniquet. And this is very prominent, especially in orthopedic surgery. Some of the pharmacological methods that can be used We have systemic medications like tranexamic acid, recombinant factor 7, fibrinolysis inhibitors, things like apoprotein. We've got local methods like the use of epinephrine or adrenaline, especially when doing local procedures. And then there are prophylactic measures like the use of erythropoietin, which can be given prior to surgery. When it comes to blood transfusion or blood salvage, you can do blood transfusion, which can be most often allogenic, or it could also be autologous. You can use the cell saver. You can employ techniques like hypotensive epidural anesthesia, which aims to keep blood pressures low to minimize blood loss, or you can use methods like hemodilution, of which there are a few methods, one of which is acute normovolemic hemodilution, and then there's preoperative hemodilution as well. When it comes to surgical cauterization, we've got a lot of options. So we have electrocautery, so you have the bipolar and monopolar, you have ultrasound devices, laser, cryogenic cautery, as well as ultrasonography or ultrasound cauterization as well. Some of the other mechanical methods that are commonly in use include things like gel foam or surgifoam, collagen sponges. We have flowables like Surgiflow and fibrin sealants as well. Things like Tisseal, Evericell. We have things like Spongostan as well. And the way all of these work is by absorbing blood and swelling, thereby creating mechanical pressure on wounds. So now we come to blood transfusion. So we're going to look at some of the principles of blood transfusions. We're going to weigh the restrictive versus liberal strategies of blood transfusion, look at the components involved as well as the complications of transfusions. So when we talk about blood transfusions, what we try to do is we try to optimize patients preoperatively, minimize the blood loss during surgery, and I try to avoid any unnecessary transfusions after surgery and use blood conservation techniques as best as possible. And the use of these blood conservation techniques is something that should be planned preoperatively as well. Part of the preoperative optimization includes screening for things like anemia and correcting it, finding the cause of anemia, discontinuing anticoagulant medications or antiplatelet medications at an appropriate time. In terms of minimizing blood loss at surgery, we have all of these hemostatic methods at our disposal that I mentioned just before. And here we're going to primarily look at when to transfuse. So the NHS has NHS blood and transplant transfusion 10 commandments. And what they essentially say is that a transfusion should only be used when the benefits outweigh the risks and there are no appropriate alternatives available. It also states that your laboratory tests, so your HB level, should not be the sole deciding factor for a transfusion. It should be based on clinical assessment of the patient and underpinned by clinical guidelines, knowing that there's no universal transfusion trigger. So not all anemic patients need a transfusion. You should discuss the benefits, risks, and alternatives to transfusion with the patient and gain their consent for transfusion. The reason for transfusion should be documented in the patient's clinical record, and understanding that good teamwork and communication are essential to ensure the timely provision of blood components to support major hemorrhage, because this is an intervention that can improve outcomes in these patients. Also, knowing that the failure to check patient identity can be fatal. You must check the patient's ID band, you must cross-check the name, date of birth, medical registration number,
and confirm the identity of the patient at every stage of the transfusion process. If there's any discrepancies, do not transfuse. Also, that the patient should be monitored during the transfusion, and that education and training are the things that underpin safe transfusion practice. Yeah. So there can be a number of strategies to approaching transfusion. So you can adopt a restrictive transfusion strategy. So before there was a liberal transfusion strategy where there was a strict requirement of an HB of 10. And clinical judgment is important in these instances. For patients who are stable, giving 1 unit of blood at a time, transfusing at a lower hemoglobin, and aiming for a lower target hemoglobin than is usual are the main principles which encompass a restrictive transfusion strategy. So, for example, there are a few thresholds. These are fairly arbitrary, but that can be followed. So in a patient who is symptomatic, as in they have myocardial ischemia, you can aim for 10. In the hospitalized patient, if they have acute coronary syndromes or pre-existing coronary disease, then transfuse at 8. In the ICU, if there's GI bleeding, transfuse at 7. For non-cardiac surgery, you can transfuse at 8. For cardiac surgery, transfuse at 7.5. For the ambulatory outpatient, for example, the oncology patient receiving treatment, transfuse around 7 to 8. And in the palliative care setting, then you can transfuse as needed for the purpose of palliating symptoms. Most experts now agree that if the HB is below 8, that transfusion should be considered. And most patients, they transfuse if the HB is below 7. But of course, this depends on the clinical condition of the patient. Some of the advantages of a restrictive transfusion strategy is that it decreases the number of transfusions required. There's no difference in 30-day mortality when comparing the two. There's no difference in infection rates when comparing the two. There's no difference in the functional recovery or the length of hospital stay when comparing those two. And very importantly, no increase in the risk of myocardial infarction with a restrictive transfusion strategy. So this is to say that it is safe, yeah, and also that it is effective. There are a few exceptions to this 7 to 8 threshold, and one of those is that if the patient is symptomatic, they can be transfused at a higher hemoglobin level. If they've got chronic anemia, then their steady state might be lower than the threshold. For example, you can have somebody with sickle cell disease who has a steady state of 6.5, and that patient does not require transfusion because that's a steady state. They've been able to compensate for that from a physiological point of view for quite some time. A threshold-based transfusion does not hold for patients who are in hemorrhagic shock. Those patients may require massive transfusion, and we're going to talk about that a little bit later. And then, of course, patients with coronary syndromes, acute coronary syndromes, we have to take into consideration the patient's cardiac function in an effort to avoid volume overload in those patients. There are a few adjuncts and alternatives to blood transfusions. So one of them is called the pre-deposit. So there's autologous blood transfusion. There are pharmacological methods. There are thrombopoietin mimetics, and there's parenteral iron. So for the autologous blood transfusions, there's something called pre-deposit autologous donation. Then there's intraoperative cell salvage and postoperative cell salvage, and then there's acute normovolemic hemodilution. Some of the pharmacological methods include tranexamic acid, tissue sealants, desmopressin, and erythropoiesis stimulating agents. The most common of these used is tranexamic acid. Now, we move on to the assessment of the coagulation component. So the components of normal coagulation were overviewed earlier in the coagulation cascade itself. Now, in the pre-op coagulation assessment, we can look at the patient's bleeding history. If it is normal, then and there are no comorbidities and there's no need for laboratory testing. If there's a history of liver insufficiency, then yes, we can do their PT and their platelets. If they have an ASA of 3 or more, then you can do a full clotting profile, PT, PTT, INR, fibrinogen, platelets as well. And you can also consider special interventions if necessary. If they have an abnormal bleeding history, then you have to work out whether they're on anticoagulants, in which case they require case-by-case drug monitoring and may require certain interventions in order to correct that. And if they have clinical symptoms, then you can do a full panel, PT, PTT, fibrinogen, INR, platelets, in an effort to look for the cause of that coagulation abnormality. Thromboelastography is also a new method that is used to get an idea of blood flow and its coagulation. It uses something called the Kloss assay, which assesses fibrin function both quantitatively and qualitatively. Right, so we're going to skip over massive blood loss for now and go to thrombocytopenia. So most surgical invasive procedures can be carried out safely if you have a platelet count below, above 50, or if you have an INR below 2. Whenever treatment is indicated, then a single adult therapeutic dose of platelets should be transfused shortly before the procedure, and then the post-transfusion count checked. So it's usually done for 10 minutes. So there are a few thresholds. So for most invasive surgery, we don't want to go any lower than 50, but if you've got neurosurgery or eye surgery, your threshold is higher, it's at 100. If you want to prevent bleeding associated with certain invasive procedures, the threshold is 50. So these are for things like GI endoscopy, LPs, central line insertions, or biopsies. When we have spinal anesthesia, again, 50, very similar to your LPs. And for epidural anesthesia, we can tolerate up to 80. Right, so we come to blood component therapy and their reactions. So blood has a number of components. It starts with whole blood, and then usually you're able to take off platelet-rich plasma and red blood cells. Then there's additive that's added to the red blood cells, usually citrate. The red blood cells are then sealed off, they're cut away. The platelet-rich plasma is then centrifuged, and then the plasma is expressed off of the platelets. The platelets are then sealed, and that tubing is then cut, and then the plasma is either frozen to make fresh frozen plasma, or then frozen and thawed to make cryoprecipitate, or to make your anti-hemophilic factors. So the red blood cell component, so there's whole blood, which contains all elements, usually comes in volumes of 500 mils and has a shelf life of about 3 weeks. And we have PRBCs, or packed red blood cells, which have a hematocrit concentration of 75% because of the removal of plasma. It's usually about 200 mils, can be stored for up to 42 days, so 6 weeks, twice the length of whole blood. It's usually stored at about 1 degree Celsius. And it's expected that 1 pack of RBCs should increase the hemoglobin level by 1 and the hematocrit by 3%. And there's washed RBCs, and this is where the red cells are washed and suspended in sterile saline. There's a slightly lower volume of about 180 mils, and what it does is that it helps to remove some of the leukocytes and remove some platelets and cellular debris, but it can only be stored for a maximum of 24 hours at about 1 to 6 degrees Celsius. And then there's leukoreduced red blood cells. These are filtered or washed. Most of the white cells are reduced, They do not completely eliminate the risk of HTLV, Epstein-Barr, or CMV, but it does reduce the risk of that significantly. And this can be used primarily for immunocompromised patients. Then we have irradiated red blood cells. These are gamma radiated in order to kill lymphocytes. So that helps to prevent graft-versus-host disease. And it's used for patients who are immunocompromised or who require intrauterine transfusion. And then we have the coagulation components, the first of which is platelets. So we usually have single donor or pooled platelets, which come in 50 to 70 mils, can be stored for up to 5 days, and each unit can increase your platelet count by about 5 to 8. We also have other types, cryopreserved platelets, lyophilized platelets, and infusible platelet membranes. These are not used as often, they usually have a shorter shelf life and less functional capacity. Then we have FFP. And FFP contains multiple coagulation factors, and it's separated from, it's prepared from whole blood by separating it and freezing it within about 6 hours of collection. They come in volumes of about 200 to 250 mils and can be stored for a very long time, up to a year at negative 18 degrees Celsius. They should be used within 24 hours of being thawed in order to obtain the optimum levels of factor 5 and factor 8, because those start to diminish after about 6 hours. About 10 to 15 mils per kg is usually required in order to achieve 30% of what is required, and about 5 to 8 mils per kg is needed for urgent warfarin reversal. It's used primarily in patients who have DIC, for people with liver disease or who have dilutional coagulopathy, as may occur with massive transfusions, who have congenital factor deficiency if that specific factor is not available. And it's also used to help correct microvascular bleeding if you've got an INR that's greater than 1.5. And then we have cryoprecipitate. Cryoprecipitate contains factors 8 and 13, fibronectin, von Willebrand factor. It's usually given as 1 unit for 10 kgs of body weight. It's used as perioperative prophylaxis for patients who have a congenital fibrinogen deficiency or von Willebrand factor deficiency, or for patients who have von Willebrand factor deficiency who are bleeding, and also for correction of microvascular bleeding when fibrinogen levels are less than 100. So depending on what type of condition a patient might have, so if they've got factor 5 deficiency, you can use FFP. If they have factor 8 deficiency, it's better to use your factor 8 concentrate. But if it's not available, you can use cryoprecipitate or FFP. If you've got von Willebrand disease, again, you can use cryoprecipitate, that's the first line. If not, you can use FFP. For factor 9 deficiency, you can use the factor 9 complex, or you could also use stored plasma. The other component is immunoglobulin, and this is done through the fractionation of plasma to produce IgG, and it can be solubilized and then given intravenously. It contains about 90 to 98% of IgG, with small amounts of IgM and IgA, and it's used primarily in the treatment of Guillain-Barré syndrome, in ITP, and in primary immune deficiencies. All right, so the complications of transfusions, it can be divided into either immunologic or non-immunologic, or it can be acute within 24 hours or delayed after 24 hours. So some of the acute transfusion reactions that we encounter, we can have a mild allergic reaction, which is usually in the form of urticaria. It can be anaphylactic, which is much more severe allergic reaction, and you can have a febrile non-hemolytic reaction, and it's thought to be due to cytokines released from the blood donor leukocytes, and it's thought that the leukocyte depleted RBCs reduce the risk of a febrile reaction. Then the sepsis, if there's contamination of the blood products, then bacteria or bacterial endotoxins can get into the recipient and cause sepsis. Then there's acute hemolytic transfusion reaction, which tends to occur either intravascularly or extravascular. Intravascular is more severe. It's usually due to ABO incompatibility. These are immune-mediated reactions, and they're as a result of the recipient antibodies presenting blood donor antigens. Non-immune reactions are also possible if the red cells are damaged before transfusion, for example, due to heat or incorrect osmotic conditions. Then there is transfusion-associated cardiac overload, or circulatory overload rather, which has to do with the volume of blood transfused, which can cause hypervolemia. And then there's transfusion-related acute lung injury, which is due to the antibodies in the donor product. So things like HLA or human neutrophil antigen, which react with antigens in the recipient. And the recipient's immune system responds and causes a non-cardiogenic pulmonary edema, usually within 6 hours of transfusion. Patients with TRALI usually do not have any risk factors for acute lung injury, and there's usually a very clear time-related relationship with the transfusion. And then we have delayed transfusion reactions. So you can have a delayed hemolytic transfusion reaction, which is due to a response to a foreign antigen that the patient was previously exposed to. There's transfusion-associated graft versus host disease, where donor lymphocytes get into an immunocompromised patient. The lymphocytes recognize the patient as foreign and react against the patient's body. The patient's immune system is unable to clear these foreign lymphocytes. And in these cases, it can be quite fatal. And then there's transfusion-related immunomodulation, which is related to circulating donor antigen that allows the development of immune downregulation, but the mechanism for this is not well known. Some of the other complications that can occur as a result of transfusion include things like iron overload, overtransfusion or undertransfusion, post-transfusion purpura, or transfusion-related immunomodulation is called TRIM. Right. So we come to massive transfusion, and this is very important in trauma. So massive transfusion has a number of definitions, giving more than 10 units of RBCs within 24 hours, giving more than 4 units of RBCs within 1 hour, replacement of 50% of the total blood volume with blood products within 3 hours, or the transfusion to support a loss of blood greater than 150 mils per minute. And there are a few predictors for massive transfusions. There's the ABC score, which is the one recommended by the American College of Surgeons. Systolic BP less than 90, heart rate greater than 120, a positive fast or penetrating injury to the torso. Each of these is 1 point. If you've got a score of 2 or more, it suggests the need for massive transfusion. If the score is less than 2, it is unlikely that the patient will require a massive transfusion. There's also another score called the TASH score, which is a little more applicable to the orthopedic patient and consists of a few more parameters. There are 7 T's of massive transfusion protocols. So there's triggers, team, testing, tranexamic acid, temperature, targets, and termination. So we're going to talk about some of the targets. So we usually aim for mean arterial pressure of about 60, systolics of 80 to 100, an HB of about 7 to 9, INR less than 1.5, fibrinogen greater than 1.5 to 2, platelet count of greater than 50, a pH that is normal, 7.35 to 7.45, and a core body temperature greater than 35 degrees Celsius. Essentially, we don't want to become hypothermic. There are a few clinical trials that have looked at various massive transfusion protocols. So the first of these is called the PROM-TT, which stands for Prospective Observational Multicenter Major Trauma Transfusion trial, which looked at patients' survival after being given red blood cells and platelets and so forth. And what it did is I looked at two arms, the red blood cell to plasma ratio and the red blood cell to platelet ratio. And what they found was that in patients who had a ratio less than 1 to 2, those were more likely to die than those who had a platelet ratio, who had ratios of 1 to 1 or higher. After 24 hours, there was no real difference. So what it's thought is that maintaining a high plasma to PRBC ratio is associated with improved survival. And then we have the PROPER trial. And the PROPER trial, it stands for the Pragmatic Randomized Optimal Platelet and Plasma Ratios, where they compared a 1 to 1 to 1 ratio to a 2 to 1 to 1 ratio of red cells to plasma to platelets. They found no difference in mortality after 24 hours. However, there was a decrease in deaths from exsanguination within the first hour of the patient's arrival, and no difference in the safety. So it is generally recommended that a 1 to 1 to 1 protocol be adopted for rapid hemorrhage control in massive transfusion. Massive transfusion comes with a lot of complications. So we have transfusion-related acute lung injury, transfusion-associated circulated overload. There's citrate toxicity as well, which can lead to hypocalcemia, hypothermia because of all of this cold blood, giving so much blood as well increases your risk of an allergic reaction. Lysis of those red cells can lead to hyperkalemia. You can also have hemodilution as a result of large volumes of platelets and plasma as well. There's dilutional coagulopathy or thrombocytopenia, which can occur. You can get febrile non-hemolytic transfusion reactions because of all of the cytokines being expressed by those leukocytes. You can have electrolyte and acid-base disturbances. There's an increased risk of infection and sepsis, an increased risk of SIRS as well, all in the acute phase. In the delayed phase, there's an increased risk of hemolysis as well as transfusion-related immunomodulation and transfusion-associated graft-versus-host disease. There's something called the lethal triad or the trauma triad of death, which can often occur from massive transfusions. And it's 3 parts: coagulopathy, hypothermia, and metabolic acidosis. So it's thought that it's lactic acidosis, decreased myocardial performance, and a halting of the coagulation cascade, which contributes to this vicious cycle and leads to problems. Coagulopathy can be caused by DIC. It can also be dilutional or due to fibrinolysis. It can be due to hypothermia in and of itself. It could be due to the acidosis, or it could be due to medications that the patient is on. Hypothermia can be caused by cold fluids, the cold blood that we're giving, things like FFP if not properly thawed, the environment as well in the operating theater or the resuscitation room, diabetes, hypothyroidism, conditions like burns, as well as hypovolemic shock. Acidosis can be caused by hypovolemia, hypercarburia, giving lactate, giving excess saline, sedation of the patient, as well as medications that can be given to the patient as well. There is a role for calcium, and some people are proposing something called a lethal diamond. So it's thought that hypocalcemia can occur due to excessive blood loss, and further transfusion then exacerbates that hypocalcemia. And of course, we know calcium is a very necessary part of the coagulation cascade, so it can lead to coagulopathies because it's a cofactor required for clotting. Low calcium levels are associated with lower pH as well, so it can lead to acidosis, and this acidosis again can prolong clot formation. And then it's also thought that it decreases the liver metabolism of citrate if we don't have calcium round and about, because the citrate that is not metabolized in the liver becomes bound to calcium, and that leads to hypocalcemia as well. So giving all of those blood products does have its drawbacks. So in summary, a hematologic assessment should begin at the time of decision for surgery, and whatever abnormalities pop up should be addressed. We should be aware of the indications for blood component therapy, the components available, as well as the complications of these blood components. Note that a restrictive transfusion strategy is preferable to a liberal transfusion strategy, and that we should know the dangers of blood transfusions. So that would be all for now.